My name is Ravinderjit Singh, and I'm a stroke neurologist at Health Sciences North and medical director of Northeastern Ontario Stroke Network. I'm pleased to introduce our speakers for the next talk, titled Post-Stroke Fatigue, Frustrated and Invisible. Our first speaker is Dr. Christine Yang. She's an associate professor at Division of Physical Medicine and Rehabilitation, Department of Medicine, University of Ottawa. She's currently the Rehabilitation Medical Director for the Champlain Regional Stroke Network in Ottawa, Ontario. She specializes in stroke rehab and spasticity management, and she's based at Elizabeth Greer Hospital, Greer Continuing Care. Dr. Yang's stroke-related research interests include post-stroke fatigue, outcome of return to work, and driving in young patients following stroke. She's also interested in fall screening for post-stroke patients, virtual reality, and stroke rehabilitation. And her research interest goes even wider, studying Botox in the spasticity management. Joining her for the talk is Patricia Rodgers, who is an occupational therapist with more than 26 years of experience working both within the hospital and in the community. Her experience includes working in various environments, including home care, long-term care, veteran affairs, and auto insurance. She has been the primary OT on the stroke unit at St. Thomas Elgin General Hospital since the inception of the integrated stroke unit in 2016. Please join me in welcoming Dr. Yang and Patricia.
Thank you for inviting me to participate in this educational event. I'm happy to talk about post-stroke fatigue, and it is commonly called by the patient or the professionals or families like frustrated and invisible. So I'm going to talk about the common screening assessment approaches, and probably very briefly talk about management, and mostly focus on the evaluating the impact of fatigue on community reintegration, especially for young stroke survivors regarding return to work and driving. So it was clearly stated or defined in the Canadian best practice guideline about post-stroke fatigue syndrome. It is often a very overwhelming sense of tiredness or exhaustion without any explainable reasons, and the person having a very difficult time to sustain routine actions. So I actually like this definition, which is actually published in Lancet. Fatigue is a subjective feeling with a motor, perceptive, emotional, and cognitive experience. And it has components of the physical, cognitive, emotional, and social fatigue aspects. So when you hear the patient report, and then they can talk pretty much everything. So the prevalence is definitely high, can be as low as 37% or 85%, depending on the literature or study. But the polled prevalence estimates about 50%. Especially for people having the acute stroke in the acute phase or recovering phase, they report significantly higher incident compared to the similar age from the general population, and especially for young stroke survivors. And this study actually showed age peaks at 40s who reported greater fatigue. And fatigue is a time-dependent factor. So it can be incidental, happened right after stroke, and recovered during the course of the subacute rehab phase, or can become persistent up to 3 years. And it is not uncommon for people reporting like fatigue as the most disabling symptoms down the road. And of course, you need to analyze other comorbidities like new medications, low sugars, pain, sleeping disturbance, or mood problems. But fatigue can present independent without other comorbidities. So we call the fatigue as invisible. How do you know? Like, how do you see? How do you know? Most often we hear the words, I'm so tired, I cannot do much, any little things can wipe me out. So we can tell, from their tone, their emotion, and knowing about their functional status, sleeping hygiene, cognitive, challenges, and the patient's the family frustrations. Yet, it's very little is known about the mechanism of the post-stroke fatigue. Of course, intuitively, you think of vascular injuries, and it can damage the brain, right? And it can slow down the cognition, the perception or motor function. Yet, the minor stroke survivors, they report a significantly higher level of fatigue compared to those with a severe stroke. The central mechanism, in terms of the cerebral inflammation and microglial cells infiltration into the injured brain was also studied. And there's one interesting, the study showing that motor fatigue often actually is more prominent, even in the absence of a motor weakness or repetitive exercise. Simply because the sensory attenuation was compromised post-stroke. That means there's kind of positive relationship between the effort perception and the level of fatigue. So people feel more effable at the basis of the muscles, no matter it's a light or no exercise. And of course, other factors, for example, people often complain, oh, if I go to the grocery store, it's just completely overwhelming. And they have difficulties to download visual information and down the aisle, like so much like to absorb, and they often over-processing the distractors. So the other factors, depression and the coping are also considered, and especially in the young stroke survivors, they may have a poor behavior flexibility when coping with a new life situation or event changes. So how do we screen and to assess the fatigue? And fatigue, post-stroke fatigue is under-recognized. And we know, like the practice guideline, we often screen in post-stroke depression, but the fatigue needs to have more attention to be assessed. It should be screened at each transitional point within the circle of care. And of course, primary care physician needs to look after all the general care issues and allied health, outpatient rehab, inpatient rehab, and even like physiatry follow-up. We need to actually raise the awareness of the fatigue screening and assessment. And there are a number of tools to assess the fatigue, because fatigue is subjective feeling and experience. So there is no objective measure. And some studies show like EMG or EEG to assess the recruitment of the muscles or brain activities. They're not indefinite. So therefore, those are common like fatigue screening assessment. The severity scale and assessment scale, they are more brief kind of, screening versus the fatigue symptom inventory, which is more specific. So I listed like a couple of examples, severe fatigue severity scale. This was originally developed to use in the MS and cardiac attack patient, but it was validated in stroke rehab population. You can tell it is based on 9 items and 7 kind of Likert scores. For anybody who actually report the mean score greater or equal than 4.0 is considered as like having post-stroke fatigue. Whereas the similarly, fatigue assessment scale is also based on the 10 questionnaire. Remember, it is more like subjective reporting, right? And then many questions around like physical and mental and social cognitive fatigue. In this scale, any score, a cutoff score is greater or equal to 24. It's in the middle of that the scale. So post-stroke fatigue has more impacts on the more energy consuming versus less energy demanding activities. And it's mostly like difficult for them to sustain those activities. And of course, fatigue also associated with the cognitive deficits, especially the processing speed and memory and attention. Many kind of studies studied the fatigue and depression association, and you can tell this is kind of mixed results. And some studies said, yes, fatigue actually is the predictive factors for, depression is predictive factors for fatigue, and the others say no, it can exist in the absence of depression. So fatigue and community reintegration, this is more often when we actually hear or when we assess the patient down in the recovery phase. They recover well in terms of physical deficits, yet they have huge, huge challenges in terms of return to work because of the fatigue. Number of studies actually indicated fatigue is an independent factor for people not being able to return to work or not being able to return to driving. Those studies are more kind of retrospective study and to actually have all the data from the large population pool and analyze the fatigue and the other outcomes. So we actually run a study to evaluate the association between the post-stroke fatigue and return to work or driving in a younger stroke patient. And this is actually a cohort study. That means once the patient had a stroke and was admitted to an inpatient rehab, we start actually evaluate confounding factors and also start screening and recording post-stroke fatigue, and mostly in the younger stroke patient, younger than 60 years old. So that is the study design. Simply to explore the confounders, particularly young stroke patients, that really affect their community reintegration. So number of independent variables were collected. You can tell this is a fatigue severity scale and stroke severity by NIH stroke score, functional limitations by FIM score, the disability scale, cognition, and depression. So the outcomes is to measure their ability to return to work or driving at different points of the time, 3 month, 6 month, and 12 month post-stroke. So when we actually assess the fatigue admission, that means incidental, right after the stroke, as predictor for not being able to return to work. So you can tell the odds ratio when people are actually reporting fatigue on admission is higher to affect their ability to return to work down the road in 6 months or 3 months or 6 months, but lost the influence down the road in a year post stroke. So that is like the fatigue admission has impact. What about persistent fatigue? So we follow those patients who actually reported persistent fatigue at each time point, and then using the univariable and multivariable regression model to evaluate fatigue itself, or fatigue plus other confounding factors. And this is the results. And no matter fatigue as an independent factor or within the other confounding factors, fatigue has a huge impact on the patient's ability to return to work. That means they have a much higher odds ratio for those with a fatigue versus no fatigue, not being able to return to work at those time points. So what about the driving? And people complain of fatigue at admission, and they said, oh, no, I cannot drive, it's just too much for me. So the driving actually has a short fatigue has a short time impact on driving. So for the 3 months, if they reported a significant fatigue, they cannot return to drive. The odds ratio is like 6 times higher than a non-fatigue patient, but lost all the impact influence down the road in 6 months and 12 months. And similarly, the fatigue, persistent fatigue, it is not a significant predictor for delayed return to driving. So again, using the multi-variable model, We evaluate motor deficits, cognitive deficits, and disability. So the fatigue itself, persistent fatigue, is not a predictive factor. Yet, not predictive factor for return to driving, yet is for the return to work. So the conclusion of this study is kind of a prospective cohort study. Fatigue remains the significant factor for stroke survivors not being able to return to work even after controlling for confounders, severity of the motor deficits, disability or functional limitations, cognitive dysfunction, and depression. And fatigue has a short-term impact on return to driving. So usually, like patient with a good physical recovery rate, and then they rate like fatigue as most disabling symptoms that really prevent them from return to work. So what does that mean? Because fatigue is invisible, and when the stroke survivors struggle with the post-stroke fatigue syndrome, people or either employers or colleagues or family members or even other professional health professionals, they cannot really acknowledge that. We work in this field, we absolutely should know the mechanism and impacts of the fatigue on the community reintegration. So it is definitely our a due diligence to educate the patient, to raise the awareness, and to actually address the vocational rehab issues, and to advocate young stroke survivors' special needs when dealing with the workplace, insurance, or any other kind of care professionals in the circle of care. So when people complain of fatigue and similarly to the depression, we say, okay, we need to prescribe some medications in addition to other kind of counseling or supportive approach. So there were studies actually for modafinil to treat the post-stroke fatigue. And despite kind of, the mixed, where's my cursor? Despite some kind of the benefits or mixed results, and ongoing actually phase 3 study in Australia, modafinil is not actually formulated medications to treat fatigue yet. So the main management still is non-pharmaceutical treatment in terms of, graded physical activities, cognitive behavior, therapy. So this is actually a good study everybody quoted, and I think it was very well done and showed great benefits for people to overcome pathological post-stroke fatigue. So therefore, back to the Canadian best practice recommendations. We definitely need to actually screen and raise the awareness for the post-stroke fatigue. I think new versions is going to have more and more evidence to support post-stroke fatigue study and assessment or management. Unfortunately, now there's limited actually evidence to support pharmaceutical treatment. Cognitive behavior, physical exercise, counseling, education remain the mainstream of the post-stroke fatigue management. And I am pretty sure, I believe Trish is going to have more information and resource to share with the audience. So take-home message, post-stroke fatigue syndrome is real. It should be screened at each time point. And the impact on the community reintegration should be addressed by all of us who involved in the patient care. Thank you very much. Trish, it'll be you.
Yeah, so thank you, Dr. Yang. That was certainly very informative. I want to talk to you a little bit more about post-stroke fatigue and some of the things that revolve around that, why sometimes we, myself included as healthcare professionals, don't talk enough about post-stroke fatigue, why we should talk about it. Of course, Dr. Yang's told us lots about that. Some of the principles of energy conservation and how we can best educate our patients, and some of the different resources that are available out there. So why don't we talk about post-stroke fatigue? Well, I know for myself, I'm working primarily in the hospital setting, and I have to admit, even though I know it's a real need, I probably don't talk about it enough. And I'm going to be honest, it's kind of boring to sit down and have that talk about fatigue. And it's tedious to sit down and discuss energy conservation with our patients. There is sometimes a lack of time to address these things. There's so many more interesting things we'd rather do with our patients. And the other thing too, I find is that after, encouraging our patients to accomplish all their physical and cognitive goals, and, we get really excited about the progress we see them make. And then it kind of feels disheartening sometimes to have those discussions with them about, well, even though you might have achieved these goals, you still may not have the energy to do all those things you want to do. But it's certainly important that we kind of overcome some of those hurdles, and so that we can really move our patients forward with more independence. And we certainly know that it's a significant issue, as Dr. Yang talked about. We often have patients come back and see us at the hospital, and we always are eager to talk to them about what some of their challenges are when they go home. And we opened our unit in 2016, so we were still kind of learning a little bit about some of the difficulties our patients were experiencing. And we'd always ask them, hey, what's going on when you get home? What are the things we didn't prepare you for? And really one of the biggest things that they would quite often say is the level of fatigue that they were feeling. And as Dr. Yang has pointed out, even years after their stroke. So some people who became certainly very independent, met their goals in the hospital, met their goals in community with their community therapists. The fatigue really was the barrier to them being able to really be fully independent and accomplishing all they wanted to within their home and beyond. So one of the things that, we can talk about is energy conservation. So a lot of you might be familiar with the principles of energy conservation, where we're talking about prioritizing, pacing, planning, and positioning. So prioritize. We're going to want to encourage our patients to prioritize and decide what needs to be done. So every person has different daily responsibilities. I see I've got a spelling mistake there, sorry about that, and levels of assistance available to them. And so we want our patients to really start thinking about all the activities that need to be accomplished throughout the day, week, and month, and eliminate any activities that are unnecessary. Eliminate activities that can be more easily done by someone else, and eliminate a job that's high energy and that you don't enjoy, so that you can have more energy for the tasks that you do enjoy. When I've talked to one of my patients about, about post-stroke fatigue, she sent me this little clip here about, you often feel tired, not because you've done too much, but you've done too little of what sparks a light in you. Now we know that post-stroke fatigue goes beyond that. But it is really important that we remember that we need to make sure we're including activities in our patient's daily plan that are going to be activities that they're going to be excited for and that they're going to be looking forward to participating in. So don't forget to prioritize those enjoyable things. And then plan. We're going to encourage our patients to make a plan. We want them to make a schedule of the activities for each day and throughout the week. We want them to allow for time for the daily exercise and rest and leisure activities. And we want them to spread out the hardest jobs to avoid peak periods of overwork. We want them to alternate between heavy and light tasks and separate cognitive and physical tasks as needed. So the method you can use is to use kind of a traffic light system. So you can have your clients look at kind of making a planner out and highlighting those activities that are going to be hard or very demanding. So, some of those things might be a concert, the family gathering, an outing, driving, and those are things that you don't want to schedule for every day. You want to have them scheduled maybe once or twice a week and spread throughout the week. Then you can choose a few activities that are sort of hard activities, and those are going to be your yellow lights, the ones you're going to highlight in yellow. So say a therapy session or doing some meal preparation or laundry or household tasks, and spread those chores around in your day and your week. And then you can have a lot more of the unlimited, easier activities, like doing some of the mindfulness, the arts and crafts, listening to audiobooks, and that type of thing. So that's one way of kind of looking at planning their day. Pacing. We want to encourage our patients to take their time when completing a task and not to rush. It's important that they rest often and rest before they feel tired, and listen to their body and know their limits. We want them to allow for plenty of time for everything that needs to be done, and be prepared that they have to stop and take a rest, and even in the middle of an activity. So they need to kind of plan ahead and say, okay, this can be maybe a point in that activity that I can take a stop at and rest if I need to. And we have to help our patients recognize that they won't be able to complete tasks in the same time frame and speed that they did before the stroke. The other thing we can look at, the last P, is positioning. So encouraging our patients to sit with it when they can, so they're not burning as much energy, and maintaining an upright posture that helps them to get more oxygen in when they're completing a task. And then using assistive devices when they can, so they're avoiding excessive bending and reaching that might use a lot of energy. So that's the energy conservation piece that we often teach our patients. And it's that tedious part that I'm talking about, the tedious part of sitting down and saying, okay, here's your handout on energy conservation, take it and follow it. But we have to remember that a lot of our patients have deficits that might impact our ability to follow those 4 Ps. So they might have cognitive deficits in planning and organizing and problem solving. So even if they know they're tired and that they need to plan things differently, they may not have the skills for planning or problem solving. They might have physical disabilities or disabilities in terms of their ability to complete written communication or read or write. So their ability to make lists or write in a calendar or schedule might be impacted. So we need to really look one-on-one with each of our patients and just see, okay, what is the best way to help them with managing their energy levels? Because some people aren't going to be capable of doing the red light, yellow light system. So we need to really work with them and find kind of techniques that are going to work with them to help set themselves a schedule. And for some patients, it might take more support than others. So how can we best educate our clients? And it's communication, and it's communication from day one. We need to start talking about the fatigue sooner than later. So it really starts in acute care and then goes throughout their whole stroke journey. And it's really important that the whole team has a role in educating patients. So it's not just the occupational therapist. We want to make sure the nurses are aware, the physio, the speech therapist, and we want to purposefully incorporate principles of energy conservation into our clients' days. So at the hospital environment, while people are in acute care and inpatient rehab, make sure you're adding rest to the patient's schedule board or planner, and really make them aware, okay, we are planning these rest breaks because of your fatigue, and this is one of the strategies to help manage it in terms of spreading activities throughout the day and providing those rest breaks in between. One thing that we do that we find really helpful is we incorporate stays in our independent living suite prior to patients going home from the hospital. So what that is, it's basically a little self-contained unit where patients have a kitchen area, their own bed, regular bed, their own living area, bathroom, and all of that. And they can practice looking after their own daily needs. So we have lots of patients who meet those little goals of they can walk fine, they can transfer, they can do their ADLs. We do the cooking assessment and they can cook just fine. So in isolation, all those tasks they can manage fine, but if you put them all together, then they start to struggle and the fatigue becomes more apparent. So those stays, in the independent living suite can be really helpful for some of our patients to really see where they're going to struggle in terms of their energy levels. And we've had patients where they don't anticipate any difficulty going home, and then after staying in the suite, they begin to realize, oh, hey, I am going to have to do things differently when I go home. So it's a good opportunity to help them prepare better. We can provide written and electronic education to our patients. We include a poster on our wall in our therapy gym, just kind of, that highlights fatigue. So it provides opportunities for us to just bring up fatigue while we're in therapy, and it, it kind of sparks that those opportunities for patients to, they look at the board and they say, oh, fatigue, yeah, I'm really struggling with that, and it helps us to initiate some of those conversations about it. So just providing opportunities, just kind of more off the cuff instead of sitting down and talking about it, is sometimes nice for our patients, and they sometimes get more out of it that way. So different resources for energy conservation. So if you do a quick Google search, you'll find lots of them. You would have been provided with these handouts that we use in our hospital. So there's the energy conservation for post-stroke. And then we also have an aphasia-friendly version of that. And you're welcome to use those and distribute those too, if you want, in your settings. There's lots of resources available on different websites, on Stroke Engine, the American Stroke Association. There's some different post-stroke checklists that our clients can look at. And then there's a few different videos available as well. So there's one video that's put out through Calgary Stroke Prevention Program on fatigue and energy conservation after stroke. And there's another one on fatigue and sleep management after stroke. So those are good videos that you can play. We've incorporated them in our hospital, on our unit. Each patient has their own TV in their room that we can upload videos to. So these videos are available for our clients to watch while they're still in hospital, so that gives them another avenue for information as well. Okay, so that kind of concludes what I was going to talk about today. But really, it's kind of that whole multifaceted approach that's really important in terms of pulling in the whole healthcare team and really talking about fatigue and really being aware of how our patients are really coping with their fatigue.
Great, thank you, Trish. Appreciate it. I did send out the little 2-page document that listed the Canadian Stroke best practices, the tips with the traffic light, and some of the resources were on page 2, the one that I redesigned from Jean Morrow. So I did send that to people, but I don't recall getting the energy conservation ones. You'd mentioned that I had probably sent them out, so I haven't.
Oh, okay, sorry about that. I'll
yeah, no problem. So if you'd like to send that to me, I will ensure that I send it out to our participants next week. So we'll ask Dr. Yang to join us again, and we'll take a few minutes for questions. People just want to type their question in the Ask Question box, and then I will share them with our speakers, and we'll get some dialogue going. Just a quick reminder, there's an evaluation for this session in the bottom right-hand corner of your screen. So if you click on that now and do the evaluation while we're doing the questions and answers, that would be great. So I'm going to start at the top. One of the questions is around why do you think it's more prevalent, that fatigue is more prevalent with young persons with stroke? Dr. Yang?
Yeah, this is exactly, what we observe or what the literature report, because one of the mechanism is, young stroke survivors, they usually recover well from neural deficits. and yet their expectations or coping are different from an elderly counterparts, right? So they expect them to be back to the baseline, active in the sports or physical, in family activities, and of course the work and the driving. So they often actually put themselves in that spot and say, you know, I'm well enough, and the colleagues or the family members view me like well enough. Why can't I? So this is kind of like mismatch of expectations and their ability, and yet in the absence of the neurodeficits. So therefore, they come to us very frustrated, and then we need to analyze many other factors before we say pinpoint this is the fatigue. And truly fatigue can be the only or one of the most three disabling the symptoms. So often we view younger stroke survivors, they actually reported higher and more significant fatigue. Plus, the more energy consuming activities versus the less energy demanding activities, they also make a difference. So they have a hard time to sustain or to multitasking, versus you only go there, just like fetch things, water from the fridge, as you really have that sustained physical and mental attention. That's when they report so much fatigue.
Right. Okay. And can you elaborate a little bit on the using exercise to combat the post-stroke fatigue? You want people to be exercising more, and that helps improve their level of fatigue. Is that what you were saying?
Yes. Yeah. I often counsel the patient. I said, you know, this is considered as a pathological fatigue because, you know, no reasons and no exercise or no physical activities can be pointed out, and you have no reasons, you know, just have that fatigue. So that pathological fatigue, if ever, you know, without any medications to treat yet, graded physical exercise, starting with the 15 minutes of walking daily or like 3 times a week, that can help to overcome pathological fatigue. It basically, you know, increase your stamina and physical conditioning intuitively, right? But in the meantime, to prepare you mentally, say, yes, my body can handle that. And it's simply just like, I perceive more fatigue after the mild or to moderate intensity of the exercise. So train yourself, either the body or brain or mind, to adapt to the graded physical activities, and they realize they can do that. Mostly people say, yes, starting in the spring or summertime, I feel much more energetic because I exercise regularly. So that helps.
Very good. Thank you. A quick question about the screening tools. Is there one that's better for community as opposed to for an inpatient hospital stay? Or can you use kind of any one of the 4 that you mentioned, kind of anywhere along the continuum of care?
Yeah, I use both because they are all very brief, and just like any PHQ-9 screen post-stroke depression. The fatigue severity scale was more kind of widely studied in the stroke population and in the research studies. It is not difficult to use. I actually use that one as primary, but doesn't matter. You can use both, and in the inpatient or community setting.
Okay, and then the one final question, I think, for your area, is it more difficult to recognize fatigue in acute care because it's such you're so acutely have had your stroke and many things going on? So is it more difficult to recognize that issue?
Yes, for sure.
Yeah.
And especially the Ontario quality-based procedure, and they ask patients to complete all the stroke workup and treatment and ship to the transition to a rehab sooner. So maybe the screening was not valid. I don't know, you never know, because we haven't started doing that yet. And acute care, they screen depression. And why can't we screen the fatigue? The only thing we observe is that once they move to rehab, subacute phase, they are supposed to participate, they have that stamina to participate in rehab, yet they report significant fatigue. So true, absolutely in the stroke rehab phase, subacute phase, we need to screen. But I do see the value to screen as a baseline in acute care.
All right, good point. Yeah, great, thank you.
And
Someone has
if I can
mentioned,
just add
Yeah,
to
go
that,
ahead.
maybe if you don't mind, I think that, from my experience, we've even had patients who we don't notice the fatigue while they're even in rehab. And then once we send them home, I do some work in the community as well, and I followed up with some of them, and that's where their fatigue becomes even more apparent.
Yeah.
Because we are naturally giving them those breaks in the hospital, and once they get home, and especially as Dr. Yang said, with the demands on younger families, they're trying to participate in the same way that they would have before. So for some patients, it doesn't even become apparent until they're actually home.
Right, thanks, Trish, good point. One of our registrants today is just stating that normalizing feelings of fatigue by discussing it early can help patients better understand why they feel as they do. I thought that was a great point that she made.
Yeah, simply acknowledge it and let people know this is true, this is real, already help them.
Right. Trish, you mentioned using your independent living suite, and I know here in Sudbury on our inpatient rehab unit, they use weekend passes, kind of in the same way, I would think. So they send them home for the weekend, and then they can report when they come back because it's more normalized at home. Do you ever have an opportunity to do weekend passes where you work?
We aren't allowed to do weekend passes anymore since COVID started. So that's a real unfortunate thing. And actually, I'm hoping to start approaching management again to allow us to start doing that again, because it certainly is beneficial, and really beneficial, especially for some of those patients who are struggling from a cognitive perspective, to be able to go home because they rest better at home than in the hospital environment. And it gives them that break from some of the stimulation in the hospital from other patients, and they just kind of like to have their own space. So and then it does give you that opportunity just to see how they're coping in all aspects when they do have that time at home.
It's a good point. I know we stopped our weekend passes as well during COVID, and to be honest, I'm not sure if they've started up again. So I was speaking from my experience pre-COVID.
Yeah.
Another question is, what have you come across in your practice as being the best description or write-up of post-stroke fatigue? One that's clear and simple that can be shared with maybe the caregiver, the partner, work colleagues, employers. Do you have a favorite one that you can recommend, or a favorite go-to from the ones you showed?
I'm sorry, I didn't get that.
Yeah, I think they're asking Trish about some of her education materials that she used, and if she has a favorite go-to one to share with people that have had a stroke in their families, or even employers, just to help educate them on the problem of fatigue.
Like kind of how to define it?
Yeah, like what it is and how to.
I mean, I think I would just say, an inability to have the energy to do all of the normal activities they'd want to do.
Is there a handout that you're aware of that people can be using with their patients and their families?
More to take, like to employers and stuff? Or to
Yeah, or even just something that you can give the patient and their family, just to, further understand fatigue.
Yeah, so on our energy conservation handout, it does discuss post-stroke fatigue. So yeah, so I'll provide you with that handout. And the first section of it is actually talking about fatigue and kind of that, how people experience that. So it provides that a little bit of that education. Yeah.
Okay, and then the other thing we were thinking of is that you mentioned the poster that you put on the wall in therapy, and it sounded like it was something that you guys created. And would you be willing to share that with people here today too? Could you send it to me that they could utilize it as well?
Yeah.
And Trish, in your resource, you shared that is that Heart and Stroke, the foundation, they make that stroke journey of it, and there's a chapter of the fatigue. I think, you know, every stroke patient, when they are admitted to the acute care, they got that booklet. So that's something very well written there.
That's right. Yeah. And we have a stroke passport as well that we give out to all our patients when they come into the hospital, and we include a section within that on fatigue. So there's certainly lots of sources of information, but it's always something that you have to kind of specifically highlight. One of the things that we do is it's included on our checklist for when patients are discharged. That the nurses will, even with people who are being discharged from acute or rehab, it's part of the checklist that the nurses will share with family and the patient, just, you know, talking about the post-stroke fatigue as well.
Mm-hmm. Yeah, really good. Yeah, we have your stroke journey book across the Northeast as well, and many of our hospitals will give that out to patients and ask them to carry it through their continuum, you know, to outpatient and to the community. So thanks for bringing that up. We really like that resource as well. I have been informed that now we're doing passes only to inform discharge planning at this time. So we haven't gone back to kind of full weekend passes like we did pre-pandemic.
Yeah.
Another question, what would you recommend telling patients who ask you when they can expect their fatigue to improve, or will it last forever? In particular, I'm thinking of a patient who's almost 3 years post-stroke.
Well, this is a very actually practical question, and almost all the patient would come to ask the thing. And I always say, you know, and all depends on the natural course. So for in my practice, for young stroke survivors, I usually follow them up to 2 or 3 years. So from there, I'm able to kind of monitor and tell their course. So my experience, and also based on the research study, if a person has a persistent disabling fatigue up to 2 years or beyond 2 years, this would likely become permanent, and it is very disabling, I have to say. But often they recover around a year or year and a half post-stroke, that timeline, provided that they really follow the strategies they were taught. Physical activities, you know, pacing and cognitive strategies. If they actually go through the whole span, and they do recover, they do.
Yeah, good point. So to our person that asked the question, you know, maybe looking into how much strategy were they taught, and are they utilizing, and could you spend some more time with that they can incorporate it maybe a little better into their lifestyle and help relieve some of the issues around this persistent fatigue. Okay, so I think that's all of our questions for today. It's really informative talk. I was really pleased that both of you could join us today. So thank you very much, Dr. Yang and Patricia, for taking the time to share your knowledge with us. And I look forward to getting an email with some handouts that I will send on to participants from the course today.
Okay,
My
thank you.
pleasure. Thank you.
Thank you.